interest of time, we'll get started. And we're going to cover today a topic that is both a buzzword and an underhyped thing, which is AI. However, what are we not going to do today? We're not going to cover any AI application related to the clinical side, or we're not going to touch on RCM. I think we have many other sessions that are talking about it. So we're going to focus specifically on how to leverage, what are some of the use cases that we've seen have worked to improve your contact center, your imaging center operations. Now, what are some of the learning outcomes? What are some of the things we want to achieve? It's to gain an understanding of what are some of the use cases that you can implement at your practice. I have set for myself a personal goal for this session, which is every one of you, each and every one of you, needs to take at least one use case that you can go tomorrow to your practice or to your radiology group and say, this will bring value to my practice. This will bring value to me. And it's not going to be only the use cases that I'm going to give you. I believe a lot. I'm a teacher, and I believe a lot in the wisdom of the crowd, the collective wisdom. So one of the things we're going to share is how each of us is implementing AI to improve imaging center operations at each of our own practices. Now, very briefly, to introduce myself, my name is Edison, and since 2011, I had the opportunity to get in contact with what at that time was called CUDA, which is the framework for NVIDIA to develop some of these algorithms. And ever since then, I've been working from different points of view, consulting or private equity, and everything related to AI development, machine learning, and deep learning algorithms. So hopefully there are some things that I can communicate. We have seen national, regional, and local radiology groups across the United States. And what we're bringing in this session are some of the things that we have seen work and how they have created value for some of these centers or some of these groups. Just to get into the details of some of the things that we're going to touch on. What are some of the pretty famous, pretty popular use cases that we have seen across patient access? We wanted to start with two, and one of them is from Radiology Partners, which implemented a 3H system to improve significantly the turnaround time for the reports. And again, what we're going to cover here is mostly related to patient access and how that can drive significant value for your operations, your imaging center operations. And then as well, Northwell leveraged some virtual assistants to ensure that they had proper interactions with their patients. However, even though this was not in the agenda, one of the things that we've, with some discussions that we've had over the past few days have realized is that it's not clear the concept of AI. Really. So I wanted to take a minute to maybe explain or define what is it when we're talking about AI, what is it that we're talking about? And there are many concepts thrown around about AI. You hear things like AGI, for example, which is artificial general intelligence, which is something that is a utopic future where we'll have machines that can replicate basically human intelligence or even exceed it. We're not there yet. What we have is mostly what is called ANI, which is artificial narrow intelligence. And these are applications that can perform very well right now a specific task, even exceeding what some of us humans can do. And this is the focus for the learning session today. And whenever you hear AI, one of the things that it needs to have as a must is that it takes inputs and converts it to an output. But the difference between AI and some of the other technologies that we typically use, we have used for the past 50 years, is that AI can then turn an input that it hasn't seen before, so something that it didn't have as an input in its code base, and turn it into an output. And then that's what makes AI, because we've seen a lot of confusion around, okay, is this AI, is this RPA, is this some other form of technology? The key element, the key ingredient that an AI needs to have is that it needs to be able to process some input that it hasn't seen before. And how does AI accomplish this? We're going to touch on it, but basically there are two different forms. One is called what is supervised learning, where you take a lot of data, input it into the AI, and the AI creates some of these black boxes that we hear a lot with some of these deep learning and subsequent perceptions. However, as we mentioned before, let's get to the gist of it. Because what we want is to really give you what are some implementations, what are some use cases that imaging center operations have seen work with AI, be it with a deep neural network or some other form of machine learning. And we wanted to start with a very specific use case that we have seen, which is patient no-shows. This is probably an issue or concern for most radiology groups in the States, which is patients who schedule an appointment and then don't show up to set appointment. The national average for this issue is close to 10%, meaning 10% of your appointments are booked and then the patient simply doesn't show up. That means that 10% of your revenue goes out the window, significant, huge opportunity cost. However, you still have the same cost structure, right? Because you have to still pay your radiology technologists, you still have to pay rent, and all the staff at your center. So one of the things where we have seen very powerful applications of AI is in how to treat these patient no-shows. And how? What do we have to do? First, just to add some dimension to what is the problem. Just for a small-sized hospital, or a small radiology group, it could represent close to $1 million in annual loss just because of this issue. This is for close to $9 million in revenue a year, a radiology group, which many of you probably are beyond that threshold. So that means that is significant, not just because of the opportunity cost, as I mentioned, but also the financial cost associated. But how do we start to think how AI can touch on, can impact our no-show problem? One of the things we have seen is that this problem, as many problems are, can be structured and categorized. And this is tip number one. Whenever you're starting to think about AI, one of the first things that you need to look into is how does your data set look? What are the breakdowns and the KPIs that I can extract? How can I break down my data set so that it's useful for any particular implementation of AI? One of the things we have seen with no-shows in particular is that it's very heavily concentrated in a few appointments or patients that typically represent a large percentage of your no-show base. And what do I mean by this? If you see the table on the right, what you see here is a table that splits 100% of your total appointments. And we have seen this with many different radiology groups, as I mentioned, national, regional, and local. And what we've seen very commonly is that the top 5%, meaning that first bucket that you see here, has a no-show rate of close to 49%. That's significant. So half of the times, these people, which are 5% of your total appointments, don't show up. And that represents, in terms of your total no-shows, 26%. So a quarter of your no-shows are in 5% of your total appointments. And then if you go down to the second layer, to the second row, what we see here is that the second 5%, this is in 5% increments of your total appointments, that second 5% has a no-show rate of close to 22%. That means that the first 10% of your total appointments represent close to 40% of your total no-shows. What does that mean? That if you can identify, right now you don't know who these people are, but if you can identify who are these 10% of your patients that represent 40% of your no-shows, you can implement strategies that will definitely increase your revenue generation. Because this is something that we've been discussing a lot lately. We focus a lot on how to collect, how to contract. However, this is a problem that if we solve it, if we're able to address it, 10% of your revenue that is going out the window, many of our margin issues will probably be eased or will probably go away. But how do we do that? Because we don't know which patients, which appointments are that top 10%. And that's where AI comes in. Because what we've seen work is using applications of deep neural networks, and not to get too technical, but especially things like logistic regressions and convoluted neural networks have worked really well in understanding, out of your patient base, which are more likely to become a no-show. People in appointments who are very likely to not show up to the time slot that they booked at your center. And how does AI do that? So I mentioned at the beginning, it takes input, even input that it hasn't sent, and turns it into an output. In this case, it's the probability that this appointment will become a no-show. And there are hundreds of variables that we've seen needs to be the input for this type of models. But I wanted to give you a quick description, very briefly, of what are the things that we found out when we're implementing this type of model. First is patient demographics, right? And I won't get into too much detail into what are some patient demographics. We've seen, for example, the senior population is more likely to actually show up to their appointment versus the younger population. This is probably related to work-related reasons or some other factors, even health. But more, I would say counterintuitively and interestingly, distance to center. You would think a person who lives closer to the center is actually more likely to show up to their appointment. However, in the data, again, extensive data sets, tens of millions of appointments, and millions of no-shows, we found out that the people who actually live closer to the center are more likely to not show up to that appointment. And why is that? Well, we have the hypothesis, because this is what the data allows, we have the hypothesis that is due to the commitment that you need to have to actually plan your commute once you are at least further, a bit further away from that center where you're getting your appointment. Some of the things are more intuitively. For example, the more out-of-pocket expense that a patient has, the more likely he is to not show up, as well as the type of exam. If it's a screening mammogram, for example, the patient is significantly more likely to not show up than if it's a diagnostic exam. So if it's a diagnostic, they are way more likely to actually show up. So using all this data and a combination of all these things, what we have seen is that we can significantly predict what is the likelihood that this patient, or this appointment, because the model itself is related to appointments, not necessarily the patients. But there are variables that are highly predictive of when a patient will show up or not show up. The highest predictive power that we found is in the median income, which we extrapolated using the zip code, and also the patient previous behavior. Meaning that if a patient not showing in the past, they are significantly more likely to not show again in the future, obviously. But there are some other things. I mentioned a few, but even weather data. Once you incorporate weather data, these are highly predictable of no-shows issues. The lead time. The lead time is a significant one as well. The further away an appointment is, if you book a person 3 months into the future versus if you book them for 10 days into the future, the likelihood is way different. So using all those things, there are many different applications that we have seen with these type of models. But just to give you a sense of how powerful these things are, some of the things that we have seen really work is that you can use what we make the symbol to the airline model, right? Or as you may know, most airlines overbook their flights, expecting some passengers to not show up. So using AI, using these data sets, you can design a similar model where you are expecting some patients to not show up so you can overbook your slots and maximize the efficiency of your high fixed cost machines, right? Because, this is something that we have to be mindful of, especially in radiology, because you have a high fixed cost asset, which are all these machines that you have in your centers. So using a similar approach, we have seen 5 times and even 10 times the return on investment just because you're being mindful of this issue and implemented a very simple, I would say, model. Again, a logistic regression is something that many of data science teams can implement. And again, using this type of model, you can significantly impact something that represents close to 10% of your total, the total revenue for your center. Now, how? Again, I mentioned the overbooking the time slots. However, one of the things that we also need to be mindful of, and I was at a session yesterday that mentioned that we typically don't track how we impact patient satisfaction. The goal of AI, because you just flip a coin and say, okay, I'm gonna overbook this slot and this time slot. But then you're gonna be affecting patients who are significantly likely to show up. What we wanna do here is just, affect what we call the big offenders, right? The people who are actually not going to show up, and maximize the efficiency that we get. And using AI, you can use parameters like something called confidence intervals, where I can say, okay, with a 95% confidence that this person will not show up, I can make sure that I have close to complete certainty that I'm gonna backfill that slot, and at least one of the 2 patients that I schedule is not gonna show up. So that's the power that we have seen. And also, some of the things that this model can be used for is to maximize the efficiency and the efficacy of the confirmation programs. Most of you are probably running some type of reminders program through SMS or through other channels to these patients. However, what we've seen is that these typically don't work. So you can design more engaging and more powerful reminder campaigns, reminder programs, so that these patients can actually be engaged in another way, like for example, a phone call, or even if you want to do another type of outreach, some type of economic penalty as well. That's something that we've seen some of our clients implement, our partners implement. And again, as this issue is so heavily focused on a few, that top 10% of your appointments, then there are some ways, once you identify them, that you can implement to significantly impact that problem. And I want to bring up another quick use case that we've seen really work, which is scheduling errors. And obviously, we all have, especially most outpatient radiology centers, we deal with these issues where we have significant staff constraints, or we needed to hire and ramp up significantly our scheduling team, and now they're making a lot of errors. Some of the things that we have seen is that out of the total cancellations, because we mentioned the no-shows, right? No-shows are one component of those same-day cancellations. And there are others related, for example, to the prior authorization, which may lead to a cancellation. That whole package of revenue leakage that significantly impacts your revenue generation ability. But one source as well that we have seen is really impactful is scheduling errors. You schedule a patient at another location, or you schedule a patient at 8 a.m. And then at 9 a.m. at a location that was 10 miles away. Or you schedule a male patient at a women's only facility. Some of the things that we have seen. Or even, things that are even risky. We can get an exam that is a stat, the referring physician didn't specify it, and then all of a sudden we have an issue where the scheduler, who is not highly trained, might need to know out of the gate, okay, this, based on the description of this exam, this needs to be scheduled in the next 48 hours, right? So how can AI be impactful in this type of situation or this type of scenario? And what we've seen is that many of the schedulers right now can be enhanced, let's say, by something that is close to a co-pilot for scheduling. And what do we mean by that? Right now, there's a lot of human judgment that the scheduler needs to have. There's a lot of protocols that they need to remember and they need to know, and it leads to errors. It's prone to errors. So once you have either a knowledge base or a tribal knowledge that a person needs to remember, that will inevitably lead to some type of errors that will inevitably, again, lead to some form of cancellations. And what we have seen is that this can translate, and again, this is something that most radiology groups are not necessarily monitoring. What's the impact, as well as the no-shows, but what's the impact of having those errors, those scheduling errors? And just to give you a sense, these are some illustrative examples on how this can affect your center, but only a tiny error rate of 5% for the mid-sized center that I mentioned, close to $10 million in revenue, can become close to 1.2 million in missed revenue, lost revenue, out of the gate, affecting your margins and significantly affecting your center's performance. Let alone if this error rate is significantly higher, just because we have a lot of new people in scheduling, or we have a system that is not as as UX friendly. It doesn't have a UI, UX that really supports the scheduling process, which unfortunately many RIS systems are. So this can escalate fairly quickly, and this can be a significant revenue leakage. So what are some of the things that we have seen that actually impact? Using something called NLP, which is natural language processing, what some of our partners have done is that they have taken that referring physician notes, or that order or that prescription that we get, right? And the reason that we use NLP is because, as you know, this is in human language, as we call it, right? In natural language. However, using AI, you can actually leverage that is in that natural language and understand, okay, based on this type of exam, we can translate this type of description in the referring physician order. We can translate it into what's the probability of an exam that our scheduler needs to perform or needs to schedule. Okay, let's say, for example, that there's one case that we saw the other day. The referring physician said heartbeat confirmation for a pregnant woman for an ultrasound, for example. That means that the scheduler needed to understand that if the baby was still alive, right? And the knowledge base was incomplete, so there's no way for this scheduler, which was fairly new, to know that this was the case. This needed to be a stat. However, using this tool, we can map and understand, okay, if the doctor uses these words specifically, then the exam that you need to schedule needs to be a stat. And again, there might be some even legal considerations associated with not scheduling the proper exam for that you can avoid just by leveraging these type of tools in AI. Another that I can give you is when a patient has a history of blood clots or DVT, usually, again, that exam will be some form of stat. And again, most schedulers, especially the new ones, won't be trained for those edge cases, those type of very particular scenarios that they don't see every day, right? Because it's not something that they see on a daily basis. So those type of things, once you embed NLP into understanding how to schedule that order that came in, can be very effective in making sure that they are scheduling the right exam. And again, that avoids both cancellations and some issues with patient satisfaction, or if some say even more importantly, some issues with the referring physician satisfaction. So, and this is specifically how you do that. It's something that we can show specifically. If you want at the end of the session, feel free to get close to us, and I'll show you how it works specifically. But it's very simple. It's a simple prompt that takes in an input from the referring physician and it spits out what is the likelihood that each type of exam needs to be performed. The other we have seen where AI has significant impact is in insurance eligibility and verification, right? And most of the tools that you see out there are leveraging RPA, which is fine because what we want is not necessarily that our tool, BAI or VSP or VRPA, is that it provides business impact and business value, right? However, there's a new subset, let's say an emerging theme in AI, which is called agentic AI. Probably you've heard the term, right? Some of these NVIDIA shows. And agentic AI will probably replicate or exceed whatever we're doing with RPA right now, probably exceed those capabilities in imitating what the human does in the computer. And this is a prime example on how we have seen very early, still in early development. This is bringing a lot of impact. However, it's still very early for agentic AI to be used at mass scale. However, what we've seen is that you can significantly replicate most of the insurance eligibility and benefits processing just by leveraging this form of agentic AI that is either connected to something called LLMs that you've heard, right? There are some medical ones like the Gator from NVIDIA, but the most common ones that you hear are Anthropic or OpenAI, which are the big dogs, let's call it, in the space. However, one of the things that we have seen specifically in these insurance eligibility and benefits estimate, we have seen some imaging centers that have achieved leveraging agentic AI close to a 40% reduction in the time to verify. That means that you can be significantly more efficient just by leveraging very inexpensive tools and very inexpensive tool set. And the accuracy rate, which I could say is even more important, significantly shoots up, close to 15% improvement. And again, this is just early stage. At some point in the next 2 to 3 years, we believe that this will take over the whole process, going even into the prior authorization piece. So I won't spend too much time on this because one of the things, as I mentioned at the beginning, that I wanted to do is just for us to share some collective wisdom on how each of us are implementing across our practices some AI use cases that you want to share with the audience. So maybe we can use a couple of minutes for that, and then we can open the floor for questions as well. So anyone wants to share what are some of the things that they have implemented, how they have seen work, what they have seen work in terms of AI for their operations? Anybody?
I guess I'll share one.
Yeah.
This one helped increase follow-up recommendation orders come back into the practice. So we had a results AI that we send all our results to, finds the follow-up recommendations. And our baseline before this was about 28% of follow-up recommendations becoming an error or an order coming in. It went up to like 45%. A little bit, increase, but it helped with an AI solution. Yeah. Without any extra labor to monitor it. It's really just work on its own.
Yeah. That's one that we've seen is very common as well, right? Basically, if there are some follow-ups that you need to do, then using AI, you can, and again, this leverages what I mentioned before, which is natural language processing or NLP to understand whatever was in the results and then automatically input or output that there's a follow-up to be made at X date. This is very powerful as well. And another one that I can share that some of our radiology groups that we have worked with have implemented is not necessarily related to what we did. We have seen from other third-party vendors. Basically, it's the whole order intake process, and there's something called computer vision, which is what the self-driving cars are using to understand what's the space around them. You can use them also to understand things like pictures and orders, which are, as we know, most of them are faxes, unless you have built some form of integrations with the EHR CMRs. So what we have seen is that you can leverage this form of AI called computer vision to read those orders from a fax and automatically input the information into your RIS. And this saves a lot of time. Most of you will have some form of order intake team, order processing team, or labeling team that will have to deal with these faxes and then input the information. This creates a couple of problems, not only the cost associated with having that team, but also just the turnaround time, which might be a couple of days. And in those couple of days, then you might lose the opportunity to effectively serve that patient that you want to capture for your center. So that's another application that we've seen is fairly common and fairly powerful as well to impact that order intake and order processing workflow that you have at your center. Any others? Okay. If not, then I think we can open the floor for questions. Just to recap some of the things that we have mentioned. If there are any use cases that tomorrow you can implement, make sure that first you understand your data sets. That's critical. The number one thing that any AI development, any AI model will need to have is a very robust data set. So make sure that you have one and that you understand it as well. Try to stratify your data set, understand it, do some slicing and dicing so you understand it very well. But some of the things that I would encourage you to look into are things like order processing, things like turnaround time, for example. Split your data into buckets. Your no-shows, as I mentioned, or really all of your cancellations, because some of them might come from prior auth, some of them might come from no-shows, and this is a very pervasive issue. We have seen some very large clients that can have up to 17% of their total appointment base that are no-shows. If you do half of that means that you can probably increase your revenue by close to 10%, which is significant, without significantly increasing your cost base. Then look as well into that insurance eligibility and benefits estimate that I mentioned. I think that's a process, a workflow that is very prime for disruption with AI, especially with the agentic AI that I mentioned. And also I'll encourage you to look into those scheduling errors, which maybe it's overlooked by many because we don't have a realistic or a proper way to measure it. But once we do, we typically see it's a significant source of cancellations or patient dissatisfaction, and even, again, referring physician dissatisfaction. So any questions? I think we have a couple of minutes to go over questions that you may have. Yeah.
Just going back to the scenario where utilizing overbooking in the situation of where you might have a greater percentage of no-shows, what were some of the things they implemented in the cases where patients did show up?
Yes.
Not wanting to impact, patient satisfaction. So can you kind of expand on
That's a very good question. Because one of the things that we don't want is to impact patient satisfaction. The reality is that with overbooking, there's a chance that some patients that the model predicted wouldn't show up will actually show up. How do we correct this, or how do we deal with this? One is, as I mentioned, using confidence intervals, and this allows to minimize the impact of these issues. If you say, okay, I want to be certain that at any given overbooked time slot, I have 95% confidence that the two patients won't show up. And with that, there's a minimal likelihood that both will show up. That's first. But the second one is just to structure, what we have seen some of our partners do, is to structure your appointments in a way that you can fit in any also that you can leave like an empty slot in there. You're still optimizing or maximizing most of your time slot, but you can have some wiggle room for if a patient shows up, then you can accommodate it in one of the time slots nearby. So that's what we've seen typically works. However, there is certainly the possibility that even if you're using a very high confidence interval, that both patients will show up in overbooking. Yeah.
So, question: we identified, okay, we expect these patients not to show up, so then I assume I'm going to be trying to schedule other patients into those time slots. Is anybody doing anything to identify the patients that are most likely to come in so that we're not calling a bunch of people needlessly? Or are there automated systems kind of for doing that to say, hey, we can move your appointment up? What are people doing there?
Yeah. Actually, the output, the typical output of these type of models is that they tell you for your whole appointment base, the probability that they will show up or not show up. So when you have, for example, the an 83% probability, then you can classify that as a high-risk patient of not showing up. But then you have also those patients that are in the 10s, 20s, where you probably don't need to spend any effort in touching them, in engaging them, because there's a very high likelihood that they're just going to show up to their appointment.
So, but what I meant is when I'm trying to fill the slots that I've identified as high risk with other patients, trying to identify the best patients to get into those slots.
Okay. Yeah. That's a very good question as well. So this needs to be a approach using data as well. So what we've seen works best again to understand what are the parameters for that any specific time slot is that you have some form of high risk patient with medium risk patient. So a person that has a 90+% likelihood of not showing up to their appointment, and you kind of cluster that time slot with a person who has a 50s or 60+% likelihood of not showing up to their appointment. And again, that will depend on how you want to structure it, because if you want a 99% confidence that the two patients won't show up to their appointment, and again, confidence interval just means that I be 95% or 99% certain that two patients won't show up to their appointment. Then that might mean if you do a 99 instead of a 95, then you might want probably two high-risk patients in the same time slot. But that will depend on some of the parameters and how you want to approach it, and how, again, there are trade-offs, as you correctly pointed out. One of the trade-offs is that you might affect, even to a slight degree, you might affect patient satisfaction. Yes?
Would you use classical machine learning to predict those probabilities of show up, or you would just feed your data in a LAMP and say, give me something?
No, that's a good question. And we've typically what we've seen is not to get too technical, but stacking classifiers, so using multiple models, and the models that we've seen work best are some type of gradient boosting, for example, that will tell you, combined with random forest and logistic regression. So both, a combination of classical machine learning algorithms with also some even more advanced like CNNs. It's a combination of all of them that spits out the best model for this. Any other question? Yeah. If not, as I mentioned, if you want to see, we can quickly show you how the scheduling errors copilot work. Feel free to approach us. If you have any questions as well, feel free to come by and ask more specific questions as well if you want to know more. So with that, I think we can wrap the session, and thank you for coming.